As always, I would like to thank our sponsors without whom this event would not be possible. AbbVie, Bristol Myers Squibb, Amgen Oncology, Genentech, Karyopharm Therapeutics, Oncopeptides, Adaptive Biotechnologies, and Takeda Oncology. Today's topic, I haven't mentioned it yet, will be managing major side effects on XPOVIO. Many patients who are considering XPOVIO or Selinexor understand that it comes with a high side risk profile, meaning that though the drug is FDA approved, there are many side effects that could come along with taking this treatment. Although that's not true for all patients, I know several patients who are on Selinexor that did not get any adverse side effects. It still may seem daunting or scary to be on Selinexor or to be considering Selinexor with this fact out there in the universe. I wanted to bring your attention to this fact. Your treating physician should be monitoring you closely so that you don't have to worry about these side effects, but we also have an expert here today to tell us how to moderate and manage these side effects that could come with XPOVIO. And I would like to introduce her at this time. Just a reminder that Molly cannot answer your personal medical questions. During the question and answer time, we should only be asking general medical questions. I don't know why my brain's not working today. As I said, it's now my pleasure to introduce Molly to you. Molly Oswald, RN, MSN, AG, NPC, CCRP, is a research nurse practitioner with the Division of Hematology Oncology at UCLA. She has been at UCLA since 2017 and provides care for patients on a wide variety of hema malignancy clinical trials, including Karyopharm's multiple myeloma selinexor trial. She primarily cares for patients with multiple myeloma and leukemias. Prior to UCLA, she worked as a nurse coordinator at USC Norris Comprehensive Cancer Center in solid tumors for 5 years. She has enjoyed working in the nursing field for 12 years after making a midlife career change. Prior to nursing, Molly worked as an environmental and biomedical engineer and manager. She has a BS in biomedical engineering from Marquette University, a master's in nursing from UCLA, and an adult gerontology nurse practitioner postmaster certificate from Cal State LA. Molly, we are so excited to hear from you, and the time is now yours.
Okay, great. Thank you, Audrey, for that great introduction. And thank you, the myeloma crowd, for inviting me to speak today on this very important topic. And I also want to thank all the patients out there who are part of this support group. And I'll also be interested to hear how your experience has been with Selinexor. So I will share my screen. Let's see.
And I'll just explain real quick, Molly. Her audio is sounding a little bit funny, so she called in so that we could hear her clearly. So that's why you see her face, but she's speaking from the phone. I just wanted to clear that up.
Okay, so you can see me though, right? You can see my video too?
Yes, yeah, we can.
Okay, great. All right. So as Audrey mentioned, I'm a nurse practitioner at UCLA, and we've had 2 of the multiple myeloma trials here with Selinexor. So I've seen quite a few patients and cared for quite a few patients on Selinexor. And I use the term Selinexor rather than XPOVIO just because that's what I'm used to working at an academic research center. And sometimes I may go back and forth. So I just want to clear that up so I don't confuse anybody. So as you know, the side effects can be quite challenging. However, if they are managed well, they can definitely be controlled. So before we jump in, I'd just like to share with you the cover of my local community. So, so as I was saying, before we dive in, I'd just like to share with you the cover of my local community newspaper from last week. This is a picture of the devastation of a wildfire that came through, started in Pacific Palisades and went through the Santa Monica Mountains. And this picture is, of course, very sad. Fortunately, no human life was lost. But it also sends a beautiful message And the quote by Rumi, "The wound is a place where the light enters you," is a very profound quote, and it's one of my favorite quotes. So I just want everybody just to take a moment and reflect on what that means to you. So life can throw us curveballs when we least expect it. So I'm sure many of you never thought in your wildest dreams that you would ever have a diagnosis of multiple myeloma. And it's what we do with those curveballs that can really make a difference and matter. So some people find like personal transformation and others spiritual growth. So Rumi's quote brings us hope and inspiration. And within this hope lies all the new drugs for multiple myeloma that have been developed in the recent years, and also those yet to come. And Selinexor is one of those drugs. So today we're going to talk about the mechanism of action of Selinexor, as well as the side effects, some of the treatments for Selinexor, and then we'll do a Q&A. Okay, skipped one here, sorry about that. So Selinexor has a novel mechanism of action, so it's a new mechanism of action that has never been seen before. And this new mechanism was approved in 2016, or it's the first new mechanism since 2016 for the treatment of multiple myeloma for patients who have received at least one line. And it's designated as a Category 1 therapeutic option under the NCCN guidelines, the National Comprehensive Cancer Network. And this is based on the high level of evidence. So this is based on several clinical trials. So you can see here just a timeline of the approvals that Selinexor has gained. In 2019, in July, it gained its first approval for relapsed refractory multiple myeloma for patients who have received at least 4 prior therapies. And then in 2020, it received its approval in June, which was its second approval, and that was actually for diffuse large B-cell lymphoma. And then most recently, in December of 2020, it received its third approval in multiple myeloma for those patients who have received at least 1 prior therapy. And that was the Boston trial, which I'm sure you've probably heard of, where it was combined with Velcade. So here I wish we had the full screen because this is somewhat animated, but I know you recently had a talk on how Selinexor works. So I won't dive too much into this, but just a brief overview. It inhibits what we call XPO1, which is a transporter. And you can see here, XPO1 is the red little horseshoe-shaped object. And then it transports proteins that are on the right here, these tumor suppressor proteins, from the nucleus out to the cytoplasm. And in multiple myeloma, as in actually other cancers, this transporter is overexpressed. So there's basically too many of them. So this transporter is transporting out all of these proteins, or a lot of these proteins, into the cytoplasm, and we want them to stay in the nucleus where they can do their job. So for example, tumor suppressor proteins, they suppress tumors, and they only do their job, they can only do their job in the nucleus. So we want them to stay in there, and that's where Selinexor comes along, and it inhibits this XPO1 transporter, so these good proteins can stay in the nucleus so they can do their job. So no drug is without side effects, and Selinexor is not without collateral damage. It unfortunately does get a bad rap sometimes in the community, and I think this is primarily due to its GI side effects, which it is most well known for. But they are manageable. It's best if we catch them early, and also best if we treat them preventatively or prophylactically. One thing to keep in mind is that Selinexor does not cause any major organ toxicity. So, excuse me, it doesn't cause any liver damage, it doesn't cause any renal damage, which many patients with multiple myeloma already has some type of kidney damage. There's also no cardiotoxicity, such as carfilzomib, which is out there, which can cause heart failure, and also it doesn't cause any neuropathy. And it's very important that we do frequent monitoring during the first 3 months of treatment. So that basically means, as Audrey was mentioning too, that you want to make sure you stay in touch with your provider. And you want to get weekly lab checks. So basically, we want to be checking your counts weekly, and we also want to be checking chemistry weekly, just to make sure that nothing is out of whack. And don't be afraid of dose reductions. Dose reductions may be necessary. And that is one area that some patients may get nervous around, but I can say that we have had patients who have maybe started on 80 milligrams and have been dose reduced all the way down to 20 milligrams. And still, I had one patient who was at 20 milligrams of Selinexor. It was combined with another treatment, but she remained on that for over a year in remission. So this here is a list of all the side effects that occurred in more than 10% of patients that were on the STORM trial. So the STORM trial, I won't go through each of these individually. I'll just hit the highlights. But the STORM trial was the first trial for Selinexor with multiple myeloma patients. And this was Selinexor with dexamethasone. And you can see here that the big side effects were, of course, the fatigue. The number in parentheses is the percentage of patients. So 73% of patients had fatigue of all grades. And I'll go over what those grades mean too in some upcoming slides. Nausea was also fairly prevalent at over 70%, as well as decreased appetite, decreased weight, both around 50%. They kind of go hand in hand. Diarrhea, not as prevalent. Not many of my patients actually get diarrhea, at least I haven't seen that. And then hyponatremia. So these are some of the big side effects that we'll cover in more detail. And this here is also the side effect profile for the Boston trial. And that trial was when Selinexor was combined with Velcade. So I put this here just because I want to point out that when Selinexor is combined with another agent for multiple myeloma like Velcade, the side effects can be actually significantly less. So you can see here fatigue actually dropped here for any grade to only 42%. So it's the previous slide, I believe it was like 73%. And then nausea is around 50%, diarrhea 32%. So all of these dropped significantly actually. And then one thing also with the nausea, which was very interesting with this trial, was that after patients had been on Selinexor and the Velcade for about a month, their nausea started to resolve. So it actually plateaued and then resolved in many patients the longer they were on it. So the common side effects that we'll cover today are the fatigue, nausea, vomiting, and diarrhea, loss of appetite and weight loss, decreased sodium levels, low blood counts, and then ocular toxicities, which are actually quite rare. So some of you on Selinexor may have felt like this guy on some days, just really wiped out, maybe like you've been hit by a truck. The fatigue can vary. Many patients find themselves either mildly fatigued or profoundly fatigued. And usually it occurs right after dosing. I have had some patients say that they feel fatigued like the second day or the third day after dosing, and they know that that is just the day that they have to take off and take to themselves and just relax and take care of their body. And fatigue is experienced actually in 80% of all cancer patients, cancer-related fatigue. So when you add a treatment on top of that, that can also cause fatigue, that can compound the effects. So here are some of the symptoms of fatigue. This is based on the ICD-10 criteria, which we use for coding and billing. So you can see that, I mean, fatigue is kind of a general term. So what does that really mean? Well, some people just basically see it as like diminished energy, but it can also cause like generalized weakness, diminished concentration, decreased motivation. You just don't have the interest in the activities you used to have. maybe sleeping too much, or you can't even fall asleep, or feeling unrefreshed or non-restored. And sometimes there's a struggle just to come over inactivity, so just a struggle to get up and do anything. And then some people get emotional when they're fatigued, sadness, frustration, or irritability. And also some people have difficulty performing daily tasks and short-term memory problems. And then also if you do get out and like go for a walk or something, you may have this post-exertional malaise, which can last much longer. So this is kind of a busy slide here, but there's some really good content on here that we should go over. So here, you can see here that this is from the Boston trial again, that 28% of patients experience grade 3 fatigue. And that's basically when your fatigue is not relieved by rest and your self-care is limited. So you cannot bathe anymore, you cannot toilet anymore, you have trouble eating by yourself. And all grades was 59%. So all grades would be the grade 1, 2, and 3. And so this is how we determine grades for the patients and how we determine dose reductions. So grade 2 is basically, again, fatigue is not relieved by rest, and it limits your instrumental activities of daily living, which basically means like going out shopping or balancing a checkbook or fixing something to eat. And then grade 1 is just, you know, you're really tired, you have the symptoms of fatigue, but it's relieved by rest. So first of all, you want to make sure that the fatigue is definitely caused by the selinexor and not by some underlying cause. So for example, dehydration can cause fatigue. So we want to make sure that you're well hydrated. You should drink about 8 glasses of water. And then also, I'm sure anemia, many of you have experienced anemia. And if your hemoglobin drops below 8, that can typically cause a lot of fatigue too, in which case you need to be transfused. So we hold the selinexor if we see grade 2 that lasts longer than 7 days, or a grade 3, definitely. And then we wait and monitor until that selinexor or the fatigue resolves to a grade 1, and then we can restart the selinexor at a lower dose. So some of the things that we use for fatigue in my clinic, one of the go-tos has been methylphenidate, which is also known as Ritalin. And we dose that usually at 5 milligrams, start out at 5 milligrams in the morning. And we can increase that actually to twice a day. And typically then we go up to just at noon hour. We don't really like to give it much afternoon because then it can interfere with your sleep. So I've had many patients that we start on this, and a lot of times we don't wait until the fatigue gets to like a grade 2 or a grade 3. We'll just immediately start it, especially if, for example, I had one patient who he was out walking, 3 to 4 miles every day, just full of energy. And then he got hit with fatigue, and it was what he would call profound fatigue, but it's what we would only grade as a grade 1 because, I mean, he did not even want to take a nap, but then when he did, he felt better. So we started him on methylphenidate, and it did help. So that's definitely a go-to that you could talk to your physician about. And also dexamethasone can help with fatigue. I'm sure you've all had experiences on dexamethasone and know those side effects well, but that can give you some energy. Typically, dexamethasone is given at 40 milligrams with selinexor. And some other strategies to combat fatigue, exercise and physical activity, even though it may seem counterintuitive, it can definitely help with that. So just getting out there, just getting out in nature, forest bathing is really kind of a popular thing right now, or just getting out in a park. Plants emit what we call phytochemicals, and they can actually help lower cortisol levels in our bodies, and also help with an increase of natural killer cells, which are these cells that go around our body and gobble up viruses and bacteria and tumors. So I would highly recommend just trying to get out in nature, just sitting out in your backyard with some plants that can really help. Also know when to conserve your energy, know when just to slow down. Therapy may be useful, such as cognitive behavioral therapy. And also meditation, such as mindfulness-based stress reduction can be very helpful. You're just very like mindfully aware of what's going on and focusing on your breathing. Yoga, acupuncture is very helpful. I've referred many of our patients to, we have a wonderful integrative East-West medicine center here. And so I refer a lot of my patients there for acupuncture, and they say that it really helps with their fatigue, and there's a lot of evidence and data out there that it can help. As well as Qigong, Tai Chi, and massage. There's also some supplements that you can take, but definitely before you start any supplements, I would check with your treating physician or treating provider. Wisconsin ginseng, I know many institutions use that. Vitamin D and L-carnitine can also help, as well as UV light therapy. And then some of the other prescribed stimulants, dextro, amphetamine, which is Adderall, and then modafinil and amidafinil. I do not prescribe those, but those drugs are typically given for narcolepsy, and they can help with cancer-related fatigue as well. So moving on to GI side effects. So those of you who are on Selinexor, I'm sure many of you have maybe experienced nausea and vomiting. Again, we want to rule out other causes. Maybe it's not related to the Selinexor, it could be related to something you ate. But if it's persistent, it is most likely related. You can see here, again, that in the Boston trial, it affected about 50% of the people had nausea. So with my patients, what I do is I treat prophylactically, so preventatively. So the day before they start Selinexor, I have them start what we call a 5-HT3 antagonist, which is Zofran, or also called ondansetron. So I have them take that the day before, and then also olanzapine, which is another medication which is taken just a very low dose. We start people out at 2.5 milligrams, and that's taken at night. And the reason that we prescribe it for night is that it can also help with sleep. So it can make you a little sleepy. So those are given prior to start. And then I also recommend that my patients take those for at least the first 3 days that they're after they dose the Selinexor, if the Selinexor is given weekly, because a lot of times the nausea can last. Sometimes it doesn't start until like the second or third day. So if you take the Zofran or the ondansetron every 8 hours for about 3 days, that can be very helpful. And then it becomes more of just like a trial and error, because like I said, some of my patients really aren't affected as much as other patients. So if patients do have what we call a grade 3 nausea, that's basically where your intake is very low, you're just nauseous, severe nausea all the time, and then vomiting, which would be greater than 5 episodes a day, we're definitely going to stop the XPOVIO and then monitor until the nausea basically resolves, and then we would restart at a lower dose level. And then diarrhea, of course, the onset is usually, it's much later, it's like 50 days, it's not quite as far out as the lenalidomide. I know you can be on lenalidomide or Revlimid for like 3 to 4 months, and and the diarrhea will show up later. But the median time to onset for diarrhea was 50 days for Selinexor, and Imodium is a good anti-diarrheal medication to take for that. And then also you want to make sure that you're getting plenty of fluids and electrolytes. And some other strategies to combat nausea and vomiting, CBD. I have some patients who definitely like to take CBD. Ginger tea is a good alternative that you can make that yourself. It's just like a little slice of ginger and then add some honey to it. And then nutrition, you definitely want to avoid spicy foods. And then again, acupuncture is a great remedy for nausea. It can be very helpful. And then something you can do yourself, I actually took this off of our East-West Medicine website, is to do acupressure and do self-stimulation of acupressure point 6. So you can see in this little picture here, if you go down about 4 finger breadths on your wrist, and then you just apply downward pressure and massage that point between your 2 tendons for about 4 to 5 seconds, that can actually help relieve some of the nausea. And weight loss and anorexia, anorexia is loss of appetite, is also common with Selinexor. You can see here that appetite decrease in all grades, for all grades, was about 35% of patients in the Boston trial, and weight decrease was 26%. And of course, we want to rule out other causes as well. And I always have my patients get a nutritional consult prior to starting Selinexor, just so they know, proper nutrition, and know to make sure that if they're already thin to begin with, to maybe start like nutritional supplements such as Boost and Ensure. The median time to weight loss and loss of appetite it took maybe about a couple months or a cycle and a half to actually have those symptoms. And then if the weight loss gets to like a grade 2, which is between 10 and 20% weight loss, we're going to hold the Selinexor and then wait until the weight returns to at least 90% of the baseline weight, and then restart at a lower dose level. One thing with weight loss, I have seen patients, this is something you do really want to stay on top of. So I have seen once you start to lose weight, it's really hard to gain it back. So I just have seen patients lose and lose and lose, where we end up holding the Selinexor longer than maybe we wouldn't have had to have they started nutritional supplements earlier. And some other strategies here would be, again, CBD can be very helpful to stimulate the appetite. Just want to go back really quick. Olanzapine, that was the drug here that we also prescribe for nausea. That can definitely help with appetite as well. So it has like a dual mechanism there. And so it's very helpful. I've actually had patients gain weight with olanzapine that did not want to gain weight. And then Megace is another appetite stimulant that can be used. We don't use it so much here just because it can cause other side effects, but definitely, these are two drugs that you may want to talk to your physician about if you're having these issues. And then going on to other strategies, definitely always have like a snack with you if you're out shopping or something. And it's good to have like small frequent meals, even if you're not hungry, just eat a little something. Like nuts are very nutrient dense and caloric rich, as well as dried fruit, avocados, always carry like a protein bar. And fasting is very popular right now for a lot of reasons. It helps reduce inflammation and it's good for longevity. And there's even studies out there for cancer, but I do not recommend any fasting while on this trial while on this on Selinexor for obvious reasons. So low sodium is another side effect. And again, we want to make sure that we rule out other causes. So some other causes of low sodium, which we also call hyponatremia, could be like using a diuretic or hyperglycemia. So sometimes high sugar can cause low sodium. So we grade these as well. You can see that about 60% of patients, so it's fairly common, had low sodium at all grades, and 14% had really low sodium, so that like less than 130. So if the sodium does get below 130, we're definitely going to want to interrupt the XPOVIO and then wait until that sodium comes back up to a good level above 130, and then we'll restart at a lower dose. And some of the treatments for low sodium would be like, if it's really bad, sometimes we'll just give IV normal saline. Also salt tablets. Salt tablets come in like 1,000 milligrams or 1 gram. So just maybe one of those twice a day would work. And this is where it's really important to make sure that you are getting your weekly, especially when you first start Selinexor, that you are getting your weekly lab draws, because it's important to stay on top of your chemistry and make sure that the sodium isn't dropping too fast, or that we catch it early. And other strategies, basically dietary modification. So I've had patients who maybe just are like at 134, like low level normal is 135. And I just tell them, hey, just go ahead and, eat some salty foods. And I know like salty nuts, again, are good. Saltine crackers and chips, not always the healthiest, but definitely, it's important that you get your sodium. So that's you know, you have to do what's most important at the time. Also, like miso soups or just canned soups in general have a lot of sodium, as well as like V8 or vegetable juices have quite a bit of sodium. And then do watch your water intake, because if you are hydrating too much, just water itself, that can also lower your sodium. So that's where like electrolyte drinks are good. You may want to try like Gatorade, maybe like the sugar-free Gatorade. Coconut water is good. And I know there's many new energy drinks out there these days. And thrombocytopenia is another side effect, just low platelets. So you can see here in the Boston trial that 92% of patients did have some dip in their platelet levels. Only 43% had a significant dip. So this is where, again, it's very important to have weekly office visits so we can check your counts regularly, because we don't want these to drop too low. And some of the signs of low platelets would be, you know, you're noticing you're bruising more easily, or perhaps your gums are bleeding, or you're just noticing, you know, like bloody noses. That's usually like the first sign that somebody has low platelets that we see, is like, oh, you know, they just start having like a light bloody nose. So if platelet counts are just below normal but above 75, we'll still maintain the dose. If they're between 25 and 75 without bleeding, some institutions give platelet growth factors. We don't give those so much at UCLA, but I know many other institutions do that, and some have some good success with that. If there is bleeding involved, we definitely want to interrupt the XPOVIO and then wait until the counts come up to a good level, and then we'll restart at a lower dose. And definitely if platelets are below 25, we're going to interrupt. And then we'll transfuse, sometimes at 25, but since there's typically a platelet shortage at our institution, we wait until platelets get below 20 or below, and then we'll transfuse. And then I've seen platelets come up pretty quick, so we usually don't have to hold for very long. And then here, these are the other hematological adverse events, such as low neutrophils. So low neutrophils are, neutrophils, as you know, are infection-fighting cells. So it's really important that we keep those at a good level. If they drop below, or if they're at like 500 or drop below 500, we're definitely going to want to hold the Selinexor. And the nice thing is that we can give Neupogen or another GCSF growth factor to stimulate neutrophils. And so we can bring those up pretty quickly too. And then anemia, that's where we need to monitor weekly again for that. Hemoglobin decrease was 71% in actually all grades in the Boston trial. So it can be common if it does get below 8 again, we're definitely going to want to give a blood transfusion. And then I just threw an ocular toxicity here. You can see here that it is not all that common. 22% of patients did have cataracts when they were on Selinexor, and 13% had blurred vision. I did have just a handful of patients who did say that they had blurred vision. So we always got an ophthalmology exam. So we had that for baseline. So we got that prior to starting Selinexor. And that was mainly because these patients were on a clinical trial and it was required. So out there in the community, I don't think that that's necessarily a requirement, but it's something that we had. And then if a patient complained of any slight symptom of blurred vision at all, we would have them have a follow-up ophthalmology exam. And nothing was ever found on those exams. I did have 2 patients who had to have cataract surgery while they were on Selinexor. But it's hard to say, you know, if whether or not Selinexor really contributed to that, because these patients were at an age where cataracts are quite common to begin with. So the dosing with Velcade, XPOVIO is given at 100 milligrams weekly. And it's basically you take it until disease progression. It's also given with dexamethasone, the 40 milligrams weekly. That can be split typically over 2 days. We have split that even over, 3 or 4 days for some of my patients, depending on how patients tolerate dexamethasone. I know Some people are taking Selinexor out there with just dexamethasone. So then the dosing may be different. You may be taking it, I believe the dosing is 80 milligrams twice weekly. But keep in mind that dose reductions are very common, and it's nice that we can dose reduce. Here, this is what's recommended per the FDA label. The first dose reduction would be if you start out at 100, down to 80, and then down to 60, and then down to 40. They say here to permanently discontinue after 40. Like I said, we have had patients on 20 milligrams of Selinexor, and they've done fine. And then the nice thing is that like once symptoms resolved, you can actually re-escalate. So you can go back up and increase the doses as well. So the median dose of XPOVIO is 80 milligrams per week. So you can see here that most patients did, or the median, so half the patients did have to be dose reduced to about 80. And then dose reductions due to an adverse event or a side effect occurred in about 64% of the patients. And then permanent discontinuation was actually quite low. It was only like 19%. So just to summarize, the major side effects that I see in my clinic with Selinexor are fatigue, GI issues, nausea, not so much vomiting, but definitely diarrhea, weight loss, anorexia, hyponatremia, the low sodium, and then the hematological toxicities such as low platelet, low neutrophils, and low hemoglobin. Again, there's no major organ toxicity, which is really nice because I know there's drugs out there on the market now that do cause like significant ocular toxicities where you have to get an eye exam prior to every infusion. So the nice thing about Selinexor is that there's all these other side effects that could be mild or more severe, but there's no major organ toxicity. So that's why many patients can stay on for so long, because all these other side effects are manageable. But again, we need to catch these early and stay on top of it, and then frequent monitoring is required, and then side effects are often proportional to the dose. So again, do not be afraid of dose reductions, and know that once those side effects are controlled, you can always re-escalate the dose as well, and work with your physician or provider on that. And then I just want to close with the super flower blood moon. I don't know if anybody was up super early this morning. I think it showed at 4 a.m. Pacific time, but this is just a reminder for all of us to embrace the wonder and the awe in the world. And that concludes my presentations at CCLA. And thank you so much, and I'd be happy to take any questions that you may have about Selinexor.
Awesome. Thank you so much, Molly. I really appreciate you going with the flow with the with the technical difficulties, and that presentation is just amazing. I saw your slides before, but hearing them out loud is just, to me, another testament as well of the importance of being a proactive patient, of being an empowered patient, and knowing that communicating with your doctor is absolutely key. So let me quickly share my own screen just to show you how this question and answer is going to work. So if you have any questions, you can raise your hand. This is at the bottom of your screen. You should see this little icon that says raise hand. And if you click that, we'll call on you in order to ask your question. And then there's also the chat above where you can ask your question. I saw people using underneath this icon is called activities. There's also a question and answer there. You're welcome to ask your questions there as well. Google Meet is interesting that it gives a variety of ways for you to ask your questions. So feel free to use any of those. And let's get started then on answering these questions. So we have one, Molly, and forgive me if I pronounce this wrong, but it's Orab Mas. If you want to unmute yourself and ask your question. And again, you can unmute yourself by going to the bottom of the screen and clicking that microphone button. I don't hear you yet. I do see your question in the question and answers, so let me ask that unless you have a different one. But he's asking if there are any taste issues, Molly.
I haven't seen that with any of my patients. So I would have to say no, I haven't really seen any altered taste. I know Tracy, who is the nurse liaison for Karyopharm, is on the call too. Tracy, do you know the data? Has there been like any dysgeusia reported? Dysgeusia is the medical term that we use for like altered taste.
No, not at this time. Nothing reported.
Okay, that's good to know. If you are having those kind of side effects, that would be something definitely to bring to your treating physician. So thank you for asking that question. I had a question. I think Elise has a question she wants to ask as well. Let me ask mine and then we'll go to Elise. You talked a lot about drug dose reduction, and I've heard of that from many patients that they started out at that 100 and then they've gone, oh my gosh, they've reduced. Thank you for my brain finally connecting. I've also heard it the other way, that patients start out at a lower dose because of different comorbidities and then they increase their dosage. But my question is, how efficient is it? How efficient is it? Does it work as well as we're lowering the dosage? What have you seen? What is your experience there?
Yeah, so my experience has been that there still is efficacy at the lower doses. So like the one example that I gave was the woman, my patient who was on Selinexor. We started her at 80 milligrams. And then because of her nausea and fatigue, we had to keep ratcheting down, and we got all the way down to 20 milligrams. And then that was like her dose that she was on for over a year. And we kept doing myeloma labs, every month. And she remained in remission at that dose. So it is definitely effective and efficacious at the lower doses, and especially if it's combined with another treatment.
That's so exciting.
Yeah, and there's what they call synergistic effects too. So when selinexor is combined with another drug, such as Velcade, we start to see synergistic effects. So it's, you get more bang for your buck, so to speak.
That's great. That's great. I think, compared to, there are some other drugs out there in the market that if you lower the dosage, there's no point in still taking it, so it's so great to hear that, if you really do have those side effects that the lower dosage isn't going to affect your outcomes per se. Elise, if you want to unmute and speak to the group, or ask your question, I guess is maybe a better word.
Oh, okay.
Yeah, there you go.
Okay, I am good. You're looking at my outside deck though. Oh, here, let me put myself on there. Sorry.
It's okay.
Okay. There I am. Hi.
Hi.
Hey. Hi. So my question, I'm on Selinexor. I'm actually a newly diagnosed patient. I'm part of the STOMP trial. I'm going into my 5th cycle now, and the plan is we're gonna keep going with the Selinexor for as long as it's working, because it's working very well right now. 1 second. Hello? Oh, sorry. Okay. Sorry, somebody was at my door. Okay. So my experience has been it's good some months and not great other months. So kind of like so the first month was really rough. Second month was okay. Third month it seemed like the side effects were getting worse. So my main side effect has been nausea. That has been completely the only side effect, but it's been very very prevalent. And I've been trying really, really hard to find a way to control and manage it, because if I'm going to stay on this treatment long term, I need to be able to manage the side effects. So I've kind of noticed a little bit of a correlation. I've been keeping track of my days and my cycles. It seems like day one, I'm always hit with the worst nausea, like terrible. It's always after my week off. I get really bad nausea, and it usually lasts 2 to 3 days. But then as I go into my cycle, I find the side effects, they lessen. So my day 8 is okay. And then by day 15, they're a lot more manageable. And then of course I got a bit of a break. So that's always nice. So I guess my question is, I'm really trying to get a hold on this nausea. I'm taking olanzapine, Metonia, and I'm taking ginger pills. I'm taking it all very regularly. And also they just added Amend 2 weeks ago to my regimen. It seems to be helping a little bit, but it's still there. So I'm just wondering, I know you suggested the olanzapine, and sorry, I meant to say I'm on ondansetron, not olanzapine. So I tried the olanzapine once, and it made me really, really, really tired. And I have 2 kids, so it's not going to work. So I'm going to try. I actually go for infusion tomorrow, and my plan was to start treating myself earlier than normal. Usually I do it 2 hours. I start my nausea regime, but I'm thinking I should start it much sooner. So that's my question. When should I start my nausea regimen before my infusion?
Yeah, that's a really good question. And are you on the carfilzomib or belantamab?
I am.
Carfilzomib.
Yes.
Okay.
I'm on carfilzomib and dexamethasone,
Mm-hmm.
and I'm on 80 milligrams of selinexor.
Okay, so you're at the high dose.
Yeah.
So I have my patients actually start like the ondansetron the day before,
Okay.
and you could start it the evening. I mean, you could even start it, that morning and take it every 8 hours, prophylactically the day before.
Okay.
But it could be just trial and error too if you just wanted to try once, just to take it in the evening, and then the evening before, and then definitely before you take the selinexor then on day 1 of that cycle.
Yeah. Okay.
And then have you tried compazine? Have they tried that with you?
I haven't. No, I haven't. What is that again?
It's called compazine. That's a different mechanism of action. So there's olanzapine and compazine are somewhat in the same category. So you don't want to take them together. They have similar mechanism of actions. But the olanzapine, I know it can make people sleepy. And that's why we tell patients to take it at night. But check with your doctor, ask them about compazine. That's another drug that you can alternate with the ondansetron. Yeah. And then, one of the reasons that the olanzapine they think works so well is because one of our vomiting centers is in the brain, and selinexor can cross the blood-brain barrier. So it acts on like that vomiting center. But compazine may be very helpful. You can just, see what your provider says about that.
Sure. Thank you very much.
Sure. It's a good question.
Yeah, thank you, Elise, for your question. And how interesting. I love learning why the side effects happen, right? So I appreciate your explanation, Molly, of that crossing the blood-brain barrier. That's fascinating. We have a different question from Aura. I hope I'm saying your name right. I'm sorry if I'm butchering it, but what is the average time to relapse right now with selinexor?
Well, based on, and this is where I think Tracy might be able to answer this question better than me, because based on the different trials, it varies. So I think like the duration of response for just the STORM trial, which was the very first trial, I think the response rate was like about 3 to 4 months. Tracy, can you chime in on
That's
this one?
correct. Yes. And then the duration of response for the Boston trial, which is the combination with the Velcade, was at 20 months. So that, the difference in being a single agent and then the other is looking at the combination trial. Now, the STOMP trial that Elise was talking about, that's an investigational trial. So that's on study. So we don't have that data yet in combination. That's not part of our indications. Yeah. So different survival on how you use it.
Great.
Yeah, and I'll just add too with the STOMP trial. So I have quite a few patients on that trial, and a lot of my patients, they've been on for a year. One patient was even on for close to 2 years. So when and that year is like they're still on it. So I have these patients that started a year ago, they're still on it. So it looks like, depending on the treatment arm that the patient is getting, they can be on for quite some time. So it's getting to the point now where, you have to wonder, well, like, especially during COVID, like we wanted to put patients on this drug because it was all oral. And especially when it was paired with like pomalidomide, it was a really good option. And I know, a lot of these myeloma drugs, we're seeing really good response rates now, to the point where they're wondering if it's better to keep people on drugs or go to auto transplant, when patients are initially diagnosed.
I think the other thing to remember too, just to kind of keep it in perspective, those are median numbers. So those are averages. So there are some that, based on their clinical situation could have been shorter, and we have some that could be also a lot longer. So there's never a guarantee as far as timing, but it can be within that span. So those are averages when we look at research, and that's what we term with that, just to make sure we clarify with that.
Perfect. Thank you. That helps a lot. I really appreciate that perspective. And I really like, Tracy, what you said about the averages. I think that's key to being a proactive patient, is remembering that you are, you might be the average statistically, but that you are not the average, and that you can fight for a better life, especially with by educating yourself. And we have one last question, and we'll finish with this. So they're asking what's the indication? Who is it for? We heard Elise, who said she's a newly diagnosed patient, but that's a clinical trial. So who is Selinexor approved for right now?
So right now, the approval in combination with Velcade is for patients who have had at least one prior line. And then for Selinexor alone, or with dexamethasone, so as a doublet, it's for patients who are relapse refractory and who have had 4 prior lines.
Perfect. Thank you. Thank you so much, Molly and Tracy, also for your input. And thank you all for being here today. We're going to close with a couple of announcements. But again, I'm just really thankful for the participation here, because that's what makes a meeting, in my opinion, apart from the excellent presentation that you gave, Molly. So next month, we'll be meeting on June 23rd at 1 p.m. Eastern, and we'll be sharing Selinexor stories. So these are some of my favorite events, where we come and we talk with each other about our experiences, how long we've been on Selinexor, how it's affected us. I think hearing collectively from a lot of people is going to be able to help us understand the drug more, and also be able to make it, especially as we bring this data together, we can help contribute to critical research that's being done. We're trying to get a guest speaker for that one as well, to highlight their story and then communicate our stories together. So I will keep you updated on that. There are also other events in the Myeloma Crowd Community Program coming up that you might be interested in. There are several that are listed here. I'll just highlight a couple. We have the African American Myeloma chapter. On Thursday, we're going to be sharing stem cell transplant experiences with Danielle. She's going to be sharing her experience with us. Friday is our nutrition and wellness for myeloma chapter. We're going to have a radiologist from Cornell come show us real images of how poor nutrition or good nutrition can affect our bodies. So I think that's fascinating. June 1st is the financial chapter, and this one's exciting because it's clinical trials, how to find them and find your out-of-pocket costs that might incur. And then Wednesday, June 2nd is our Qigong, which Molly mentioned is a way to help combat fatigue. So if fatigue is something that you're struggling with, make sure to join us Wednesday night as a master of Qigong is going to be teaching us. And those are a couple of the events that I wanted to highlight. Oh, excuse me, the link to sign up for any of these events is at the bottom of the slide, and these will be shared with you in a follow-up email along with the recording 24 to 48 hours after this event. Another thank you to our sponsors, AbbVie, Bristol Myers Squibb, Amgen Oncology, Genentech, Karyopharm Therapeutics, Oncopeptides, Adaptive Biotechnology, and Takeda Oncology. And thank you for helping us build a strong myeloma community. I appreciate you and hope that you have a great rest of your day. So thank you for attending. And thank you again, Molly.
Thank you. Thank you, everybody. My pleasure.